Do we have Casulo on the line? Okay. Let me just get a quick mic check with Tatiana. Can you? Can't hear you. Okay. So I think that what makes most sense right now, we can come back to Casulo, is I'm going to go ahead and hand over the panel to moderation to Dr. Rajan Sonic. I think it's okay for us to continue. We'll have our first panelist, and then if we get a chance, I really know that many of us want to hear from Casulo, so we'll continue to work through that as well. So Rajan, if you want to go ahead and introduce our first panelist.
Great. Thank you, Efrain, and thank you, Tati, and everybody else who's helped work so hard to put this panel together. In the interest of time, Tatiana will be putting into the chat or the Q&A side a link to the full bios of all of our panelists, so you can read the full details of their backgrounds and all of the excellent work that they've done. But for now, I'm just going to do a brief introduction so we can dive right into the content, which I know everybody's eager to hear. One quick other piece of housekeeping is that we will be trying to track all of the questions, so please send those as we go along so that at the end when we have the discussion portion, we can try to do our best to get to those as much as possible. And we will be sending a survey towards the end of the panel to get feedback from all of you. So it'd be great if you could try to respond to that as well. So with that all said, I'm going to hand it over to Dr. Gary Segura, who is the Dean of the Lesson School of Public Affairs at UCLA and the co-founder of Latino Decisions. Thank you.
Hello, everyone. Thank you for the opportunity to speak to you. And I know we are all deeply, deeply concerned about the crisis facing our country, but also, and the globe, but also our people in particular. And I'm fortunate enough to work in two organizations, both of which have devoted considerable attention to this question. And I'm going to be trying to bring you up to date on what we know or what we think we know about how the COVID-19 crisis will be affecting the Latino population. So in the first slide, I want to kind of give you a head start on what my critical takeaways are. So the first is that COVID-19 can be thought of as a diagnostic tool as well as a global pandemic. It's a diagnostic tool that helps illustrate the alarming inequities that existed in our society prior to the crisis. Nothing shines a light more clearly on the incredibly disparate treatment of individuals and groups in our society than a crisis such as this. It's also worth noting that people once treated as expendable and who are even today the target of polemics and political opportunism have now been revealed to be essential to our society at their own peril, to their own safety and well-being, to keep the food system of the United States functioning. Third, and what I'm going to spend a fair amount of time on, is that the educational consequences and the economic consequences downstream are likely to be really quite horrific. So I wanted to bring you up to date on some polling numbers that Latino Decisions gathered with our partner Somos, which is an East Coast medical practice, not unlike AltaMed, but in New York City, which, as you know, has been very hard hit. This is a nationwide survey where we have representative oversamples so that we can break out New York, New Jersey, California, Florida, and Texas into separate samples. 70% of Latinos nationwide are following the news very closely, and another 24 are following the news somewhat closely about COVID. And that makes sense because 22% of all Latino adults know someone who is ill. That's more than 1 out of 5. And in New York City, interestingly, it's almost half, about 49%. Many Latinos desire to get a test. We find nationwide 26% of Latinos know someone who has experienced symptoms but is unable to receive a test because of the broad unavailability of testing and the wildly disparate and uneven availability for communities that are disadvantaged. Going to the next slide. Employment and the financial and economic consequences of COVID for our community are profound. 46% of our community has received a pay cut or a cut in hours. 43% report being worried that they won't be able to make their rent or mortgage. 35% of our respondents had someone in their household lose their job already. 33% have a significant loss of retirement. 29% who own their own business or single operators have either seen a decline in revenue or the business has gone out of business. And 18% have been asked to work additional hours without additional pay. If we think about the loss of income and add those numbers together, 65% of our respondents report losing some or all of their income already. And yet, as an irony, over a third, 36% of Latinos, are still working outside the home, and many of them are in peril for their own life. They report being afraid and not being provided with the materials necessary to protect themselves. So moving on. Many Latino families, actually many American families without regard to race and ethnicity, have relatively little in savings. Latinos are unfortunately among those. While I mentioned before that 65% had already lost incomes or jobs, and 43% are unsure they're going to have trouble making the rent or mortgage this month, many Latinos have less than $500 in the bank savings for a rainy day. In fact, 50% of our respondents had less than $500 in savings, and more than a third of our respondents had less than $100. These are people who rely on their own incomes to meet daily expenses, and those incomes are disappearing. Next slide. Many of us know of children being asked to attend school remotely, and this is K-12 all the way through college. 46% of our respondents of Latinos nationally have school-age children in the house, and half of those have more than one school-age child attempting to be schooled from home. At the same time, more than a third of Latino households either have no broadband connectivity whatsoever, or they get their only internet connectivity through their phone. So it's very, very difficult for Latino families to have their children access web-based learning environments. And in fact, almost a third of our respondents report that they did not have sufficient computers for every child and worker who's attempting to manage their lives entirely from home. A few other things to consider. As you probably know, federal policy, including the CARES Act, is excluding unauthorized immigrants from support. More importantly, perhaps, they're also excluding mixed status families. Anyone who has an ITIN number instead of a Social Security number on their tax return were excluded from the CARES Act provisions, the distributions of funds. And that includes if someone with an ITIN number had a U.S. citizen spouse and multiple U.S. citizen children, they were unsupported entirely. Latinos are already among the largest uninsured populations in the United States, and 20% of our respondents in the poll report they have already lost their health insurance in this because of employer-based losses. Anti-eviction enforcement is very lax, as we know, it's often ineffective, and the post-COVID financial trauma is likely to be incalculable. We go back to 2008 and 2009 and the Great Recession, as much as two-thirds of all Latino net wealth disappeared in that recession. We are only 10 years since then. We're only just barely recovering. Now we're taking another profound loss. Educational mobility has been recently quite excellent. In California, Latinos were the largest single population matriculating into post-secondary education last year, and yet we are thwarted again, this time by closures of schools, the loss of income, and the inevitable growth of expense. If you'd like to find more results from our polling and analysis, there are two web addresses that are going to be pasted to the chat, and I look forward to your questions, and I wish you all safety and good health.
Thank you so much, Dr. Segura. I mean, many highlights of, again, not only our concerns, but a lot to consider. And as we think about what you've shared, also to inform sort of how we develop some of our own interventions moving forward, what are the areas that we can focus on and better address moving forward? So thank you for those comments. I did want to take the opportunity to reintroduce our president and CEO, Cástulo de la Rocha, and I know that he was working very hard to get on because health equity for him has always been a priority. But also, I just want to share again, I know I've shared quite a bit about him, but he's been fearless in his resolve to ensure that at AltaMed we have the support and resources to respond to this pandemic, and again, to address some of the concerns that Dr. Segura raised in terms of testing, ensuring that we provide enough testing for our community, especially these communities where there has been very little to no testing. And so I really want to thank him for that and hand it over back to Cástulo.
Efrain, thank you very much. And I certainly appreciate the opportunity of being with all of you here this afternoon. Very wonderful presentation, and I really look forward to the other panelists in a bit. It is no coincidence that we are speaking of the issue of discrimination and disparities as a community health center. You know, health centers were designed for inner cities and rural communities, the urban poor, as well as farm workers. AltaMed itself was born out of need. We were slowly born out of the Brown Berets meeting space in East Los Angeles many years ago as a free and volunteer-run clinic where low-income, undocumented populations could go for medical services in the late 1960s. Latinos, Mexicans, and low-income neighborhoods like Boyle Heights, the community from where I grew up in Los Angeles area, lack options for culturally appropriate and affordable care, and community health centers like ours proved to be lifesavers where hospitals and private practices were absent. I would tell you, in fact, that hospitals and even public health systems back then refused to see poor people, but particularly the undocumented. I lived through that period of time. Today, nearly 20% of people in the United States are Latino. That ratio jumps to 50% in the county of Los Angeles. You're all familiar with this data. In SPA 7, where AltaMed was born and continues to hold down its foundation, 3/4 of residents are Latinos and already have their shares of health concerns tied to income-related disparities prior to COVID-19. Before this pandemic hit and prompted a rise in unemployment, 1/3 of the area was already food insecure. More than 2/3 of public school students qualify for free or reduced price meals, and approximately 1/3 of adults were obese or had hypertension. With businesses closed and individuals financially struggling, I have no doubt that need is driving up rates in food insecurity and chronic disease complications. More than 3 million people have filed for unemployment in California just over the last month. Some reports indicate, and hopefully one of our panelists would be able to clarify this, some reports indicate that over 35, in some cases 40%, of the unemployed Americans are Latinos today. Across the country, where 2/3 of employed Latinos said last month that they would not get paid COVID-19 if they were to miss 1 or 2 weeks from work. And where 1 of 5 Latinos were uninsured before COVID-19, as Gary pointed out. These populations will absolutely see financial devastations. The CDC has also recognized that people with 1 or more chronic conditions such as obesity, lung disease, or hypertension, or diabetes, are more likely to be admitted to hospitals for COVID-19. I hope that one of our researchers will begin to identify the hotspots by zip code in the county of Los Angeles and Orange. There are very vulnerable populations and communities that we really need to monitor carefully. So as we continue to fight against this virus, we cannot afford to leave behind those who disproportionately suffer from chronic conditions to begin with. Those individuals are not disappearing just because we are prioritizing COVID-19 diagnosis and recovery. Community health centers like AltaMed can continue to help fill a role by monitoring our patients' health and directing them to public resources. But we are going to need additional financial support to make sure we can stay open and indeed fulfill that role. And we need to advocate way beyond our service areas in order to elevate our populations. We cannot address the economic or healthcare disparities facing our community without acknowledging that there are minorities within minorities. Intersectionality among minorities is not just about gender or sexual orientation. It is about social categorizations. Something that we constantly have in mind in community health centers is whether our patients are undocumented and do not qualify for healthcare coverage, which certainly affects where they can go safely for care under normal circumstances. Just this past February, we saw the redefinition of the term public charge go into effect, meaning permanent residents, people here legally, will be potentially penalized for using public resources, and you're familiar with this, Medicaid, housing assistance, and nutrition assistance. We know that more than half of Latino population in LA County were born abroad, which means many are permanent residents who are subject to public charge-related fears or the limitations that come with being undocumented. They also disproportionately work in blue-collar jobs and do not have the option to work from home and self-isolation. And we know that while those undocumented may be able to access COVID-19 tests with symptoms, they are not subject to unemployment or stimulus payments. Gary talked about that just a minute ago. From a health care standpoint, reassurance from the medical community that they are welcome in our doors may not be as strong as the anti-immigration rhetoric from our administration. So if our voices, the voices of healthcare providers, is not enough, then we need to advocate for greater representation and elevate the Latino population at all levels of government. This is precisely why this Institute for Health Equity was established to begin with, to use research and evidence-based data to highlight the best practices, the innovations, and the things that we are doing right in our community, but also to spotlight, to show and to demonstrate and to raise those issues where there is discrimination and disparities in communities, in Latino communities. We need to go and use every single source at our hands and our disposal, the airways, viral, legislators, anything and any way that we can illustrate, one, the strong opposition to the practices of discrimination in American society. But to be honest with you, I would tell you that I've read and recently reading a book that put me back in the 20s and 30s and 40s in California. Some of the same issues that we're raising today, we refer to as health disparities, were the same issues that were raised back then. The same issues about community engagement were the same kind of issues that are being raised today. but we're a very different community, and we have resources that heretofore we have not had access to. And yet, we're a long ways from where we need to do. Your support of the Institute and what we're doing here, that kind of research, the kind of discussion, intelligent discussion that we're having here today needs to move to a much higher level. Thank you for allowing me to take part in this event. I look forward to hearing from our panelists, and I am able to see whether our discussions can help create new progress in our communities. My apologies for the technical difficulties that I had in signing on, but it is a privilege to be here with all of you. Thank you very much, Efrain.
Thank you, Castelo, so much. And I'm already starting to see some questions pop on the question and answer panel. So thank you all for continuing to do that. And just to move right along, I'm going to welcome Dr. Wilma Franco, who is the director of the Southeast Los Angeles, or SELA Collaborative. Thank you, Dr. Franco.
Thank you. I'm Wilma Franco. I'm the director of the Collaborative. Thank you so much for having me today. It's kind of hard to, I'm thinking about all the things that Castelo just sharing. I think it kind of set the tone for the conversation and the discussion that I wanted to have here in terms of our work in the Southeast region. So we can move to the next slide. Our collaborative is a network of organizations, and we're very fortunate to have AltaMed as one of our members. Our work has been heavily focused on the region, Southeast LA region. If you can move to the next one, sorry. So I wanted to kind of, provide this map here because a lot of the times people ask us, like, what specifically do we reference as SELA, right? So when we talk about the Southeast, we talk about 8 cities and 2 unincorporated areas, right? So I wanted to really ground the conversation for my section here on the demographics, and one of the things that we discussed that Castelo mentioned, just understanding before COVID, what was kind of like our challenges that we were experiencing, right? So 94% of SELA identifies as Latinx population in comparison to LA County. Our region does have a higher percentage of renters, of non-high school graduates, of population living below the poverty line, limited English-speaking families, as well as the 0 to 17 population, right? So, one of the other pieces that I think we try to highlight as it pertains to SELA is the fact that our workforce is very heavy on the goods movement, as well as hospitality and retail, right? So as we're thinking about this was what we have always experienced in SELA, right? That also has an impact on the environmental challenges that our community has experienced. SELA does have a high pollution burden to our communities, which, we can't have a conversation about environmental challenges in SELA without having the conversation about the impact to health, right? And we know that a lot of these challenges have also resulted in high rates of asthma and cardiovascular disease, right? And then when we keep in mind, access to health and healthcare, 32% of our population actually do not have health insurance, right? And 40% of them identify as immigrants. We can move forward. So I think one of the things that we wanted to really kind of highlight, right, early on our work around the census, because we knew how, the census data really guided a number of the resources that our communities were lacking. So things like medical funding, food assistance, housing, transportation, all of these pieces were detrimental to just thinking about, how do we ensure that SELA has access to the resources, but not just resources, also representation, right? The political representation that really prioritizes the Southeast region, which has been historically, under-resourced and under-prioritized. We can move to the next. So I think, this is where we really kind of, wanted to focus the conversations when we began talking about the census. As we look at the previous 2010 census, we knew that 92% of our census tracts were actually fell under what we consider the hard to count population, right? a lot of that is because of our demographics. And this map, the redder it gets, the harder it is for you to actually count this community, but also the more likely that they will not respond, right? So when we look at SELA, we know that the Southeast region is the hardest to count region within LA County, which is the hardest to count county in the nation, right? So I think for us, this was something that was detrimental to, thinking about how do we ensure that our communities begin to get that resource, right? And this was all, pre-COVID. If we can move to the next. So, there was the demographic challenges and how do we reach our community, but then also there were a number of census challenges to actually ensure a complete count. A number of them were, the fact that we were in discussions early on, as early as 2018, as to whether there would be a citizenship question. The fact that the census this time around in 2020 would be heavy internet access. We have a digital divide, as you heard with the previous presenter. More than 30% of our population does not have access to broadband and internet. So what does that mean in terms of ensuring a complete count, right? And then, our communities have historically experienced low levels of trust towards government because of the demographics and some of the experiences that we've had in the past. But so all of these pieces kind of pose this larger challenge for us. So a lot of the work that we began to do in the Southeast was this regional approach, right? Like, how do we coordinate not just with what community identified as their trusted messages that were schools, youth, faith-based, CBOs, essentially all the folks that you see responding to the needs of our community, but also including the cities and elected officials, right? Like, how do we come together to ensure that as the census is happening, we can ensure a complete count and really bring those resources down to SELA, right? Next. So as we were doing this work, a lot of the activities and the strategies that were identified by our partners, our colleagues, our cities were really heavily focused on that face-to-face interaction, whether they were community education or workshop events, just really kind of trying to make it fun so that people would respond and that they would be excited about entering the census. There was also the fact that because we knew there was a digital divide, how do we open community assistance centers to provide support? Digital media was something that we knew we needed to prioritize, but it wasn't a heavy lift because we knew that in our community, we needed to have that face-to-face interaction and helping our community, in the door-to-door and phone banking. But then, COVID happened, right? And I think this is what resulted in us really kind of changing and having to reanalyze how we were looking at this. So if you can go to the next. As all of the COVID responses really kind of put out of our hands all this face-to-face interaction, like we're all safer at home, right? And that's what we want to prioritize. But then that also means that we may have bigger challenges in ensuring that our communities are completing the census, which has a direct influence and impact into how many resources are going to come to SELA, right? So I think that was one of the biggest shifts for us in trying to support our region and our colleagues and our partners in moving this work forward. If you can move forward. Thank you. And then so one of the things that we did in mid-March, as soon as we began to know that we needed to shift gears, was we actually reached out to all of our partners and we made sure that we had the input from not only CBOs, both that were funded to do census work, but also non-funded organizations, elected officials in our cities to really kind of understand, like, how has COVID-19 impacted your census outreach? And as you can imagine, a lot of the responses were, we've canceled all our outreach events. Some of them were having to reduce staff. So some of them had to lay staff off, right, which was a huge impact to the strategies and the work. But then also, I think the biggest pieces that we heard was how do we shift, because now we want and we're prioritizing meeting the needs of the community, but how do we do it knowing that census also has a direct impact, right? And some of the concerns that we heard were, we now don't have the capacity to reach residents. What does that look like for all of us? So it really kind of caused all of our CBO partners, our cities, our elected officials to begin to really rethink what does this look like for us, right? And what would be helpful moving forward? So I think this, moving forward, I think that was the piece that we knew the digital content was going to be critical, but we also have a bandwidth, challenge, a capacity challenges. So how do we make sure that it still carries through, right? Move forward. So really, some of the things that, that we've learned through some of the work is we know that through the census, we want to make sure that our communities receive the resources, right? And that's directly, correlated to that. But we also know as we have been, having conversations and leading some of this work in SELA, understanding that, we need to increase access to medical service, right? Like not just the testing piece, but what Costello mentioned around ensuring that our communities actually, already had a number of health challenges, right? And a lot of our community may not have medical services. So how do we make sure that because they're at a higher risk, because they tend to be part of the essential workers, how do we make sure that they actually have the medical services to ensure that, that if they catch, and they're exposed to the virus, that they can actually survive, right? The other thing for us was really looking at the long-term sustainability of the nonprofit sector in SELA. All of our CBOs, colleagues, faith-based organizations are responding to the need, but that also is causing them to tap into resources that may result in us not seeing a number of organizations continue to exist, right? And then I think part of the other conversations we've had is what is the economic vitality of the SELA community and cities? In our conversations with some of our cities, we know that we're very small cities, and in a particular situations, some of their revenue is 40% coming from a casino. So what does that mean for them as they're rethinking about how to support the community? But I think when we talk about this issue of equity as it pertains to SELA, we were already struggling. I think COVID has not necessarily created a lot of this problems for us. It's actually magnified and really kind of exacerbated the challenges and highlighted the gaps of where we need more support. So as we think into the future, really thinking about, the support to the Southeast region will have to be exponentially higher than, because we were already experiencing so many of these challenges, right? So I would be remiss if I don't mention, if you haven't completed your census, please go to my2020census.gov and complete your census, and please continue to encourage folks to do so. Thank you.
Great, thank you, Dr. Franco. Next up is Dr. Melissa Chinchilla, who's a research scientist at the Institute for Health Equity. Please keep the questions coming on the panel on the side of your screen. I know we're running a bit late, so we might not have this time for as long of a discussion as we were hoping, but we will try to do our best to track all of those questions and get responses to folks afterwards at the very least. Thank you so much again, and I'll turn it over to Dr. Chinchilla.
Thank you. Thank you. Thank you all for joining us for this very important discussion. As others have mentioned, including Casulo, it's really important for us to continue to work collaboratively to draw attention to the needs of our community during this current crisis and also in the time to follow. I'll specifically be talking about some of the challenges and opportunities to address the needs of our Latinx population that's experiencing homelessness. Next slide. So as you all know, homelessness has been a growing concern in communities across California. Looking specifically at the regions that AltaMed serves, in the last few years, we've seen double-digit increases in both Los Angeles and Orange counties. We have also seen a rise firsthand at AltaMed with growing number of patients self-identifying as experiencing homelessness while participating in our health programs and also while receiving clinical care. Recently, the Centers for Disease Control and Prevention noted that individuals experiencing homelessness are an extremely vulnerable population. They experience notable barriers to proper hygiene and also in maintaining social distancing. And recent research has also suggested that homeless individuals that contract COVID-19 have up to 2 times the risk for hospitalization, up to 4 times the risk for needing critical care, and up to 3 times the risk to death due to the illness. Homelessness is also likely to increase given the current economic challenges, as Dr. Segura mentioned. People are losing their jobs, they can't afford to pay rent, and even though we've seen rent and mortgage moratoriums, we expect these to soon expire. So there's clearly an immediate need to address the needs of individuals that are experiencing homelessness and those that are at the cusp. Please, next slide, please. As we all know, AltaMed's population is predominantly self-identifies as Latinx. Latinx are disproportionately represented among the working poor, and at local and national levels, we've seen Latinx homelessness increase over the last couple of years. In Los Angeles County, the Latinx population represents about 1/3 of the homeless population for the county. Then at the national level, we see that the Latinx population accounts for about 22% of the people experiencing homelessness, although they only account for about 18% of the total population. There is unfortunately limited research on Latinx homelessness, but from what we know, the population differs in a number of ways from other ethnic and racial groups. For one, Latinx population is more likely to be first-time homeless compared to other racial ethnic groups. In addition, Latinx individuals are more likely to experience homelessness with children. One number suggests that 41% of Latinx experience homelessness with children, compared to about 28% for Blacks and 12% for white individuals. Latinx households are also more likely to experience homelessness as part of an intergenerational household. All these differences that I mentioned, they lead to unique service requirements and challenges when connecting to resources. Next slide, please. So under the current crisis, we've seen an increased effort to funnel resources to address our homeless crisis. At the national level, we've had the government pass the CARES Act, which includes about $4 billion for homeless assistance. At the state level, we've seen increased efforts and funding for emergency shelter. We've seen efforts to detect COVID-19 early among the homeless population, and we've seen increased availability of quarantine spaces. At the county level, we're seeing that public health departments are increasingly collaborating with homeless service providers to make sure that individuals living on the streets have access to the isolated spaces that they need and have also proper information regarding how to prevent and stop the spread of COVID-19. However, even with these expansions in resources, the Latinx population is likely to experience notable challenges, particularly when it comes to connecting to resources. Next slide. So through our through our previous research in LA County, homeless service providers have noted that in the last couple of years, the number of Latinx individuals appearing to be homeless on the streets has increased, but they're seeing few individuals actually come in to receive homeless services. This observation has been supported by previous work by the California Policy Lab, which has examined service receipt in Los Angeles County and found that compared to other racial ethnic groups, Latinx are least likely to engage with homeless services. So for instance, in 2018, about 35% of the population that was homeless self-identified as Latinx. And when we looked at the number linked to permanent services, only about 25% were linked to permanent housing, and about 21% were linked to permanent housing, and about 21% were placed in permanent housing. So there's quite the differential with regards to need and actual service access and housing placement. Next slide, please. We've been conducting research at AltaMed to better understand how patient-facing staff are assisting our patients that are experiencing homelessness and some of the barriers that they're seeing for service connection. They've mentioned a couple of different things with regards to barriers. They've found that Latinx are least likely to connect to homeless services for a variety of reasons, including lack of familiarity with the homeless service system. So as I mentioned, Latinx individuals are more likely to be first-time homeless. So therefore, they are least likely to be familiar with how the service system runs, a system that can often be very convoluted, confusing, and frustrating for many. Another thing that our respondents have mentioned within AltaMed is that many Latinx individuals don't self-identify as experiencing homelessness, so they don't identify with the term homeless, and there is also still a lot of stigma around receiving services. In addition to that, as Casulo mentioned, we've seen increasing concerns around public charge and the receipt of resources. So a lot of individuals are not connecting to services because of the fear around immigration. Next slide. So with these challenges to service connection in mind, AltaMed is working to make sure that providers are assessing patients' housing needs and properly referring patients to available services. As I mentioned, many new services being offered at the county level. We are also working to inform providers of the culturally appropriate ways to inquire about homeless status. As I mentioned, we've repeatedly heard that if you ask Latinx individuals if they are homeless, they will say no. But if you ask more descriptive questions, for instance, where do you live? How long have you lived there? Will you be able to stay there for more than 14 days? You're more likely to get an accurate response. In addition, at AltaMed, under the leadership of a homeless task force, AltaMed has begun undertaking essential work to increase program and service linkages for AltaMed patients experiencing homelessness. This incredibly important work needs to continue both during COVID-19 and in the time to follow. I'll go ahead and stop there, and I'm happy to answer any questions.
Thank you, Dr. Chinchilla. We're going to hand over to the last presenter, Jolene Bastos, who's our Director of HIV Services. And while she's presenting, please look at the panel on the side. We're going to be posting a number of links. So we'll post the link to the bios once again, to a resources page that the AltaMed Communications Group has created, and then also a link to our survey that I mentioned at the beginning. So thank you all again, and again, keep the questions coming, and I'll hand it off to Jolene Bastos. Thank you.
Thank you so much. Good afternoon, everyone. My name is Jolene Bastos, and I will be presenting on COVID's lasting impact on HIV services. So I wanted to start out to talking about HIV services at AltaMed. HIV services are provided within the Daniel Victor Lara clinics. We are a one-stop shop, comprehensive HIV medical service. We offer PrEP, PEP, HIV testing, and safer sex education. It is important to point out that we were offering rapid HIV testing at 3 sites prior to COVID, but we have consolidated to a single site at Indiana, and are one of the few agencies in LA continuing to offer this service. We have received referrals from larger partner agencies during this time, and actually on April 13th, we had 6 walk-ins for HIV testing. Sorry. Next slide. So I wanted to talk a little bit about the 90-90-90 HIV treatment targets. This is something that is incredibly important in the HIV field. We're looking at having 90% of the population aware of their HIV status, of which 90% would be on HIV treatment and 90% virally suppressed. Ideally, 30 million people would be on antiretrovirals, and fewer than 500,000 new HIV infections would occur annually. Next slide, please. So there are several concerns thinking about feared increases in STIs and HIV toward the end of the COVID epidemic. The first wave of concerns is due to patients who are currently at home and not seeking screening and treatment. When the stay-at-home order begins to lift, we could definitely see an increase in STIs and HIV. The second wave of concern comes when the stay-at-home order begins to lift. We're all going to understandably be jubilant and want to return to venues such as dance clubs and bars. This may lead to us throwing caution to the wind in regards to practicing safer sex, i.e. not using condoms and not taking PrEP. Other concerns are intimate partner violence, coercion, and survival sex. You know, survival sex at this time could be high due to loss of income for many. People need to eat and they need to pay for shelter. Next slide. So the Health Resources and Services Administration, HRSA, awarded $90 million for Ryan White HIV/AIDS program recipients across the U.S. to prevent, prepare for, and respond to COVID-19. This money will assist us recipients to better respond to this new threat in our communities while maintaining our ability to provide HIV primary care, medications, and support services. DVL received funds for both AltaMed's Ryan White C Early Intervention Services clinics located in LA and Orange counties, and Ryan White Part D Wiki clinics, which is women, infant, children, and youth services located in Orange County. So some of the ideas we have in how to spend those funds are enhanced education and outreach efforts, supplies for respiratory hygiene, enhanced infection control training, PPE, laptops for telehealth. That's something we're all talking about right now as how we're reaching our patients and able to engage them and keep them in care. Meal deliveries. Current resources in the community are limited and really bogged down right now. Having texting apps for our computers, assistance with transportation. You know, subways and buses are not exactly the safest places to be right now. Bus stops and laundromat COVID advertisements within the neighborhoods that we serve, and webcam and microphones for interventions via technology, thinking about our consumer advisory boards, our evidence-based interventions, which are a large part of provision of HIV prevention services. Next slide. So what are the opportunities in HIV and our asks after COVID? So how do we improve certain historical restrictions? So medical and behavioral telehealth visits, to have the funders continue to pay for these types of visits. 90-day medication supply for those who are virally suppressed and adherent, increased education and outreach around PrEP and PEP, increase STI and HIV testing and treatment, engagement, again, via technology. I talked about our CABs and our evidence-based interventions, and enhanced collaboration. I think now more than ever, we realize how much we rely on one another, and really, really ensuring that we're connected with the communities, our local communities, and working well together. Thank you.
All right. Thank you so much, Jolene. So there were a couple of questions. I know it's after 2. If folks could stay a bit longer, we're just going to continue just for 2 questions, just for the sake of being able to have a little bit of the discussion. But then after that, we're going to try to amalgamate all the questions and do like an FAQ for the questions that we didn't get to. So please keep sending those if you have them. One question, you know, is highlighted by Jolene just now, related to telemedicine came in. This one came in through Vanessa Hernandez Zermano, and I'm going to direct this to Efrain. And it was about telemedicine, and the question was about how telemedicine and nurses can further help in regulating clinic flow and providing more access to the community moving forward. Obviously, there's been this big move right now to do telemedicine, but as we get to a post-COVID world, how can we continue to leverage that new technology?
Yeah, I would say that telehealth broadly is not only a way for us to address existing clinical concerns, but also people are going to be a lot more willing and have already started to share a lot of the social concerns, right? Losing jobs, needing disability, needing support around food and or home or housing issues, legal issues. And so I do see that our provider partners, our nursing team, along when we're putting together these visits so that folks can access clinical care, they can also start to screen. And we have a screening tool within our EPIC system, our electronic health record. So really being intentional about documenting and being able to have those needs, and then having us at the Institute continue to work with a multitude of collaborators across AltaMed and our community partners to really ensure that there's a linkage, that we close the loop, that we have those patients who have needs be able to access services, and or we can partner with the community partners on making sure that those services are supported. Many times our community partners are looking for our support, our advocacy. We just got an email yesterday about us continuing to advocate for our homeless community in Orange County. And again, being able to address some of the regional variation that we see in services. We know that some communities have some resources and others don't. And so that's a big challenge for us because we are positioned within many underserved communities, and every community has its own challenges. So we're very sensitive to that, and we will continue to share resources. I know that's part of the next and follow-up, but also use technology. I think technology, whether it's telehealth, text-based, or other ways, social media, connecting people to services is a huge, we know, driver for better health. So doing the clinical and addressing social needs.
All right, thank you, Efrain. One more question, and this was for Dr. Segura. A lot of folks have talked about the current crisis revealing the lies behind the rationales often given for very strict and harsh regulations and policies that disproportionately lead to negative consequences for low-income communities. And as some of these restrictions are lifted because everybody is now facing some of these challenges, what are some opportunities you see longer term to take advantage of that sort of realization and in terms of trying to get fairer rules for society moving forward after this crisis?
Implicit in that question is a very hopeful scenario, and I love being hopeful. And it's clear that the crisis is a leveler in its own way. It is the case that Latinos and African Americans are dying at much higher rates, but it also is an indicator of the importance that many people doing minimum wage jobs have to the functioning of this society. You would hope that that becomes an opportunity to message for greater leverage, for greater political equality, for better treatment. I wish I could tell you I was as hopeful as the question suggests. I'm just not convinced that it's going to be easy to do that. I think people during times of crisis tend to look inward toward themselves. I can imagine a scenario where the society becomes even more insular, and events today are even consistent with that. I do think, however, that it does lay bare what the motives of the people at work are, and that's actually helpful in the public sphere. We know that there are a lot of non-Latino Americans who are people of goodwill, who do not intend social violence, who do not intend social disadvantage, and calling out the effects of the types of things that they're voting for may actually have a long-term positive effect as they come to realize what they're doing. So I guess that's my hopeful element. But the expendable became essential. I'm just deeply afraid that the essential will become expendable once again.
Thank you, Dr. Segura. No, and it's a strange time where we have to have a mix of realism, pessimism, and optimism. There was a request to out of curiosity to throw that same question to Castelo, particularly as we think about the roles of FQHCs in the pre-COVID world in the midst of this crisis and looking forward. What are the opportunities you see for us as or FQHCs generally to help advance equity in light of the critical role that we're playing right now?
Okay, there you go. Thank you very much to all of you for this extraordinary panel. The challenges that FQHCs are facing across the United States, in California, and in every state of the union are very similar. There's just not enough support in the community, whether it's the federal government, state governments, local governments, financial support. It's been very difficult to come to the dollars that we need to be able to maintain our doors open at most of our facilities. I will tell you that I'm extraordinarily proud of the kind of work that the medical staff at AltaMed has done in preparing AltaMed to take on the challenge of COVID-19. The leadership of Dr. Cheryl Brown, Dr. Talamantes, and others on the staff of AltaMed has been extraordinary. I think that we have done as much as any community health center would be expected to do to deal with the issues of COVID-19.
We were one of the first to put out testing sites. We have a total of 9 testing sites today. Between Los Angeles and Orange County, we have seen thousands of people and continue to screen thousands of individuals. We need to do that. We need to do the testing. The governor pounds his chest and says, I'm responsible for not having enough testing in the state of California, and yet we have yet to see the resources to support the sort of activity that AltaMed is presently undertaking. I would tell you that we have got zero support from most institutions to do the things that we're doing. Nonetheless, this is a responsibility, a moral responsibility that we feel as an organization to do. It's kind of interesting because what happens in our industry, and I say because in our core, the population that we serve is the uninsured. We know that projections are that 40 to 50 million new people would be added to the uninsured population. It is also the Medi-Cal population, frankly, and that is our core, it's the Medi-Cal population. In a recession-like environment today, you see a growth in the Medi-Cal population. So it's projected that between this year and next year, there would be a growth in the Medi-Cal population, somewhere between 1.5 million to 3.94 million people in the state of California. That's a business opportunity for us. So if there is a bit of silver lining, it is the growth in that market that over the course of the last several years has steadily declined. There's an opportunity. However, and the way in which we're going to have to provide services is radically different than the way we did it 4 months ago, 6 months ago. Radically different. Dr. Talamantes talked about televisits and telehealth and telemedicine. That's the beginning of what and how we're going to use technology from marketing to outreach to teleconferencing and home monitoring. You're going to see significant growth in that side of the organization. I don't think that we're going to see any less patients. We're just going to see them differently in safe, appropriate environments and social distancing. We're going to see this for a while in our clinics. We need to figure out exactly how that will be done, but it will be done. And when everything is said and done, it will be done. The last thing that I would say for our most vulnerable populations, and Melissa talked about a couple of the homeless, and Jolene talked about our HIV populations. Those are two. We have a very large senior population that we deal with. The 3 or 4 medical conditions, 3 or 4 activities of daily living, these are the most vulnerable populations that you can find exactly the targets for COVID-19. We need to figure out how to provide care. And we're talking about thousands of people, 400,000 patients at AltaMed. But to get back to the question that you asked, I think that there has not been sufficient support at a national or state level for community health centers. We need to see a major infusion of capital. There is an opportunity for us to redefine what the new normal would be. And once we redefine that, I think that we can have a much more effective, efficient organization than we have here to operate at AltaMed. And there is a market opportunity with the growth of Medi-Cal lives. We will be reborn differently between now and the end of the year, but we've been here for 50 years, and I don't plan to go away in the very near future.
Amen. Thank you, Castelo. Thank you, everybody, for joining. I'll just say one more thing is that there's opportunities to collaborate. I think the Institute in particular is built around collaboration, but AltaMed-wide also has a strong history of collaborating. So anybody who's on, go to the AltaMed website, the AltaMed Institute website. There's different forms you can fill out, and it's specifically geared towards if you want to collaborate with us, send us your ideas. This is a time where we all obviously need to work together to stem the tide of suffering as much as we can together. So again, panelists, if you could stick on a little bit afterwards as we do a wrap, but attendees, I think we're going to close. So please look out for the survey and share ideas and continue to work towards equity. Thank you all very much.